Hey everyone, welcome back. Today we're going deep into non-tuberculosis mycobacteria.
NTM.
Yeah. And to guide our deep dive, we're using Principles and Practice of Clinical Bacteriology second edition.
A classic.
It really is. For those of you in the lab, this one's a must-have. And today we're going beyond the basics. We'll uncover some real gems about NTM, stuff that can really make a difference in our practice.
Absolutely. We'll be looking at those little details that can really change how we diagnose and treat.
So first things first, why are they even called non-tuberculosis mycobacteria? I mean, what was wrong with the old terms? Atypical or anonymous mycobacteria.
Well, you see those older terms, they're a bit misleading. They just don't really reflect what these organisms are really like.
So not your typical troublemakers.
Right. They're different from Mycobacterium tuberculosis, which is a true pathogen. NTM are mostly environmental.
So they're not always looking to cause trouble.
Exactly. They might just be hanging out in the environment or even in our bodies without causing any harm.
So that's why diagnosing NTM infections can be so tricky, huh?
It really is. You really have to carefully think about what's going on with the patient.
You know, one thing that really struck me was how much 16S rRNA gene sequencing has changed how we classify NTM.
Oh, absolutely. It's like a whole new world has opened up.
The book mentions that the hypervariable region A is particularly helpful in NTM.
Yeah, and that's because some NTM species can be very similar. So similar that they have identical sequences in region B of the 16S RNA gene. But focusing on region A gives us a much clearer picture. It helps us tell those closely related species apart.
So it's a more precise tool for NTM than for other bacteria.
It is. It really helps us make sure we're identifying these organisms correctly. And that's important for both diagnosis and treatment.
And the book mentions that they're looking at other sequencing targets too.
That's right. They're doing research on other genes like HSP65 and gyrase genes. These give us even more information.
Like having extra tools in our toolbox. But mycolic acid analysis is still useful, right?
Definitely. Mycolic acids are these long-chain fatty acids in the mycobacterial cell wall. Each species has a unique pattern. It's like a fingerprint.
So we can analyze these patterns with techniques like gas chromatography and get another clue about the species. It's amazing how far we've come in identifying these organisms, and we're still finding new ones.
It's true. The NTM family is always growing, which is exciting for us in the lab. But it means we need to stay up to date with the latest classifications and methods.
Absolutely. Now let's talk about something really crucial. Their ability to cause disease.
Pathogenicity.
Right. This is so important for us in the lab, but also for our clinical colleagues who need our help to interpret results.
Absolutely. The important thing to remember is that just because you find NTM, it doesn't automatically mean infection.
Right, unlike M. tuberculosis.
Exactly. With M. tuberculosis, if you find it, you've pretty much got your diagnosis. But with NTM, it's more complicated.
Because they're often just hanging out in the environment, right? They could be commensals or even contaminants in our samples.
Exactly. So we need to be very careful when we see NTM in a culture. We have to look at the whole picture. Multiple isolates from the same patient, the type of sample, and of course the patient's symptoms.
So an isolate from a sterile site, like a lymph node biopsy, is much more concerning than a single isolate from sputum.
Precisely. Now, what are some signs that should make us think, hold on, maybe this is NTM, not something else?
Yeah, what are some red flags clinically speaking?
The most common ways NTM infections show up are in the lungs, the lymph nodes, and the skin. But the tricky part is the symptoms can overlap with other conditions.
I remember from the book that NTM pulmonary disease can be subtle and sometimes hard to distinguish from tuberculosis.
Absolutely. They both can cause cough, fatigue, weight loss.
The usual suspects.
Yeah, but there are some differences. NTM often shows up as thin-walled cavities on a chest x-ray, while tuberculosis usually has thicker-walled cavities.
Ah, so those subtle details on imaging can really help us.
They can. Sometimes the way the illness progresses can give us clues too. NTM infections tend to be slower than tuberculosis, and patients might have a history of respiratory infections that keep coming back.
Okay, what about lymphadenitis? I know it's common in kids, but how often is it actually NTM?
Well, NTM is a frequent cause of lymphadenitis in children, especially in developed countries. But other things can cause swollen lymph nodes too, you know, cat scratch disease, or even cancer.
So a good clinical exam and the right lab tests are essential. Now, how about skin infections? What should we be looking out for?
Right. Well, rapidly growing mycobacteria, those are the ones like Mycobacterium fortuitum and the Mycobacterium chelonia group, they can cause infections of the skin and soft tissues, especially in patients with implanted devices like catheters.
That makes sense, considering they're all over the environment.
Right. But we also need to be on the lookout for NTM species that cause very specific skin lesions, things like Mycobacterium marinum and Mycobacterium ulcerans. These infections have very distinct clinical features.
So knowing the specific species is key, both for figuring out what's going on and how to treat it. And that's where we, as medical microbiologists, come in.
Absolutely. Our job is to identify these organisms and guide clinicians on the best way to manage these infections.
Okay, so let's talk about the lab side of things. What are the key steps in identifying NTM? We start with a culture, right? But what else is there?
The most important thing is to use the right media. NTM are a diverse group, and what makes them grow well can be very different. Some are slow growers, some are fast, some need specific nutrients, some are less picky.
So we need to use different media to give us the best chance of finding the culprit.
Exactly. And we need to be patient. Some NTM can take weeks to grow.
So no rushing the process.
Nope. And once we see growth, we take a closer look under the microscope.
To check if it's really mycobacteria.
Exactly. We do an acid-fast stain, look at the colonies, and examine individual bacteria.
For clues about what species we might be dealing with. But I'm guessing we often need molecular methods for definitive identification.
You got it. PCR and sequencing are really essential. They're faster, more accurate, and they give us so much more information than traditional methods.
It's incredible how much these molecular tools have changed how we diagnose and manage NTM infections.
Truly remarkable. But even with all these advances, we still need to use our judgment and consider the clinical picture.
So let's shift gears and talk about how we manage NTM infections. I know this can be quite a puzzle, but what are the general principles?
Well, the first step, always, is to know exactly which species we're dealing with. Then we need to think about where the infection is, how bad it is, and the patient's overall health and immune system.
And drug susceptibility testing. That's crucial, right?
Absolutely. We need to know which antibiotics will actually work against that specific bacteria.
Are there any go-to drugs for NTM? I know it depends on the species, but are there any common ones?
You're right, it does depend on the species. But some of the key players are macrolides, like clarithromycin and azithromycin, rifamycins, like rifampin and rifabutin, ethambutol, and fluoroquinolones. We often use a combination of drugs to effectively treat the infection and to prevent resistance from developing.
And treatment can last for a long time, right?
It can. Treating NTM is not a quick fix. It often involves multiple drugs taken for months or even years to completely get rid of the infection. And it can be hard for patients to stick to these long and complex treatments, so we need to be really clear with them and support them throughout the process.
That's a great point. Clear communication and ongoing support are crucial for successful treatment. Now, I know we're going to discuss the management of specific NTM species later on.
Yes, we'll delve into those details in the next part.
But before we move on to specific species, let's talk about the bigger picture. Where do these bacteria live and who's most likely to get sick?
NTM are everywhere. Water, soil, dust, even animals. And they particularly love water.
So contaminated water systems or even aquariums are a common source of infection.
Exactly. It's pretty hard to avoid them completely. But thankfully, not everyone who comes across NTM gets sick. People with weaker immune systems, like those with HIV, are at a higher risk. Also, people with lung conditions like COPD or cystic fibrosis.
So it's all about minimizing exposure and being extra careful if you're at higher risk.
Exactly. Now that we've laid the groundwork, let's start exploring those specific NTM species. Each one has its own unique challenges.
Let's do it. Let's start with a common one. Mycobacterium avium intracellular complex, or MAC.
MAC. This one's a real head-scratcher sometimes. It can cause a wide range of infections, and it particularly likes to affect certain populations.
The book mentions MAC infections in birds. Is that a common source for human infections?
It is. Birds and environmental sources like water are the main ways it spreads to humans.
So contaminated water systems, for example.
Exactly. MAC is found worldwide, but how common it is depends on where you are, likely because of differences in the environment.
And the book talks about how HIV affects MOC infections.
Right. Before we had really good treatments for HIV, disseminated MD infection was a big problem in people with HIV, especially when their CD4 counts got really low.
But with effective HIV treatment, that's changed dramatically, right?
It has. In countries with good access to HIV treatment, M of MNC infections in people with HIV are much less common now.
That's really good news. What about people without HIV? What kinds of problems does MVA cause?
In children, we often see swollen lymph nodes in the neck. Adults can get a whole range of lung problems, from mild bronchitis to severe pneumonia. And for people with weakened immune systems, it can spread throughout the body, causing all sorts of problems.
So how do we treat MRSA infections? I know there have been some changes in how we approach it.
You're right. The treatment for pulmonary MC in people without HIV has changed. We used to rely heavily on rifampin, isoniazid, and ethambutol, but now we're using more regimens that include clarithromycin.
Why the switch? Did the old drugs stop working, or did we find something better?
It's kind of both. Clarithromycin works really well against amphiphins, and studies have shown it's really effective in treating those lung infections. And it's generally better tolerated than the older drugs, which is important when treatment can last a long time.
So clarithromycin is now a go-to drug for pulmonary MS in people without HIV.
In many cases, yes. And we're also considering rifabutin, another rifamycin. It works even better against MS in the lab, and it might be able to overcome some drug resistance.
What about surgery? Is that ever part of the treatment plan?
It can be, especially for infections that are limited to one area. For example, we often recommend surgery to remove infected lymph nodes in children.
Makes sense. Take out the infected tissue and you reduce the bacterial burden. What about for people with HIV and MAC? They obviously need their HIV meds, but do they need antibiotics too?
Absolutely. Getting their HIV under control is the most important thing. But antibiotics are also important to reduce the bacteria in the blood and prevent it from spreading.
So which antibiotics do we use for MMC in people with HIV?
We often use clarithromycin, ciprofloxacin, or rifabutin. The choice depends on the individual patient, their other medications, and potential drug interactions.
And what about prophylaxis? Do we use antibiotics to prevent MC infections in people with HIV?
We do. It's recommended for those with low CD4 counts. Macrolides work well for this, and rifabutin can also be used, although it might cause more side effects.
So again, it all comes down to the individual patient and their specific needs.
Precisely. Factors like their other medications, potential drug interactions, and how well they tolerate the drugs all need to be considered.
Let's move on to another NTM, Mycobacterium kansasi. What makes this one stand out? I know from the book that it's one of the most common NTM we isolate.
It is, and it's photochromogenic.
Photo what now?
Photochromogenic. It means it changes color when it's exposed to light. It's quite remarkable.
So if you grow it in the dark, what happens?
The colonies are creamy white, but when you shine light on them, they turn this beautiful yellow color. It's a helpful clue when we're trying to identify it in the lab.
It's like a bacterial chameleon. So where does M. kansasi hang out in the world? How do people get infected?
It lives in the environment, and we find it in water, especially in cities. Tap water seems to be a big source.
So maybe city dwellers are at higher risk?
It's possible. We do tend to see more M. kansasi infections in urban areas. Another interesting thing is that cigarette smoking and chronic lung diseases are also risk factors.
It seems to target people who already have weaker lungs.
Right. Now, what kind of illness does M. kansasi usually cause? Well, it often looks like a chronic lung infection that gets worse slowly, similar to tuberculosis. You might see cough, phlegm, coughing up blood, weight loss.
Those symptoms sound a lot like tuberculosis.
They do, which is why lab tests are so important.
Right.
While both M. kansasi and tuberculosis can cause lung problems, they grow differently in the lab and respond differently to antibiotics.
Okay, so tell me about treating M. kansasi infections. What are our options?
Rifampicin is our go-to for M. kansasi. It works really well against this species and is usually a key part of successful treatment.
And do we use other drugs along with rifampicin?
We often add ethambutol. The guidelines recommend using rifampicin and ethambutol together for 9 months, with the option to continue longer if needed. This combination is really effective in getting rid of the bacteria and making people feel better.
And what about isoniazid? It's a major player in treating tuberculosis, but do we use it for M. kansasi?
We don't usually use isoniazid for M. kansasi. Studies show that it doesn't really add much benefit and it can cause more side effects. So we tend to stick with the rifampicin and ethambutol duo.
So we've got rifampicin, ethambutol, and we might add other drugs if those two aren't enough, or if there are signs of drug resistance. What about surgery? Is that ever an option for M. kansasi infections?
We don't usually resort to surgery for lung infections, but it might be considered in very specific cases, like if the infection is limited to a small area and isn't responding to medication, or if there are complications like severe bleeding or a collapsed lung.
Okay, so surgery is usually a last resort. What about infections outside the lungs? How common are those with M. Kansasi?
They're less common than lung infections, but can still happen, particularly in people with weaker immune systems. It can involve the skin, lymph nodes, bones, or other organs.
And how do we treat those extrapulmonary infections?
The approach is very similar to lung infections, with rifampicin and ethambutol being the mainstays of treatment. If the infection is localized, like in a lymph node or a skin abscess, we might consider surgery to remove or drain it.
So the key takeaway here is that rifampicin is our hero for battling M. Kansasi, and ethambutol is its trusty sidekick.
Absolutely. Now let's move on to another NTM that can cause both diagnostic and therapeutic headaches. Mycobacterium xenopi. This one can be a bit of a trickster.
What's tricky about M. xenopi? Why is it so different?
Well, it's slow-growing and non-chromogenic. That means it doesn't produce any pigment, even if you shine light on it.
So it's not as visually interesting as M. Kansasi. But why is it considered a trickster?
It's often found in respiratory specimens, but it can be hard to tell if it's really causing an infection or if it's just hanging out as a harmless colonizer. Don't forget, many NTM are environmental, and M. xenopi loves water, including those hospital hot water systems.
Oh, right. We talked about that earlier.
Yeah.
So isolating it doesn't necessarily mean it's causing trouble.
Yeah.
We really need to consider the clinical context.
Exactly. And to make matters even more complicated, infections with M. xenopi tend to develop very slowly.
So someone could be carrying it around for years without even realizing it.
It's possible, and that makes diagnosing these infections really tricky. We need to carefully weigh the patient's symptoms against the lab results. Are they actually sick? Are there other possible explanations for their symptoms? Have we found M. xenopi in multiple samples? These are all important questions.
You mentioned hospital hot water systems. Are those a common source for these infections?
They can be. M. xenopi has caused outbreaks in hospitals linked to contaminated hot water. It thrives in those warm, moist environments.
So it likes a nice warm bath. Who is most likely to get sick with M. xenopi? Is it similar to other NTM, where people with lung problems are at higher risk?
You bet. M. xenopi tends to infect older men with a history of lung problems, things like COPD, emphysema, or even a previous tuberculosis infection. These conditions create an environment where M. xenopi can take hold more easily. And like many other NTM, it can also affect people with HIV, especially those with severely weakened immune systems.
Okay, so what does an M. xenopi infection look like? Is it always in the lungs, or can it affect other parts of the body?
Pulmonary disease is the most common way it shows up. And it can range from mild, slow-developing symptoms to a full-blown illness that resembles tuberculosis.
So patients might have a cough, fatigue, weight loss, and sometimes even cough up blood.
You got it. And because it can look so much like tuberculosis, both in terms of the patient's symptoms and what we see on their chest x-ray, we need to be really careful not to misdiagnose it.
Once we've confirmed it's M. xenopi, how do we treat it? Do we use combination antibiotic therapy like we do for some other NTM?
You're on the right track. The recommended treatment for M. xenopi lung infection usually involves a combination of rifampicin and ethambutol.
What about isoniazid? I know it's a first-line drug for tuberculosis. Do we use it for M. xenopi too?
We don't usually start with isoniazid. We only add it if the rifampicin and ethambutol aren't working well enough. Adding it from the beginning doesn't seem to provide extra benefit, and it increases the risk of side effects, so we save it for those cases where we need a little extra firepower.
Are there any other antibiotics that might be helpful for M. xenopi?
Well, macrolides and fluoroquinolones have shown some promise in the lab, and there are reports that they might be beneficial in treating these infections. However, we need more evidence from clinical trials to know for sure if they work and what the best doses are.
So rifampicin and ethambutol are our first-line defenses, and we can consider adding isoniazid or other antibiotics if needed. What about surgery? Is that ever an option for M. xenopi?
Surgery is not typically our go-to for M. xenopi. However, we might consider it if the infection is localized, not responding well to medications, or if there are complications like severe lung damage or bleeding. In those cases, we might consider removing a portion of the infected lung.
I imagine that decision is made on a case-by-case basis, looking at the patient's overall health, how extensive the infection is, and how well they're responding to the antibiotics.
Exactly. It's a complex decision that requires careful weighing of the risks and benefits. Now let's switch gears and talk about a couple of NTM species that cause very specific skin infections: Mycobacterium, marinum, and Mycobacterium ulcerans. These infections are often pretty easy to diagnose based on how they look.
Right. Their clinical presentations are quite distinctive. Okay, let's start with M. marinum. What's the typical scenario we see with this one?
Marinum is a water bug, often found in aquariums. People often get infected after contact with a contaminated fish tank, hence the nickname fish tank granuloma.
So aquarium enthusiasts and people who work with fish need to be careful. What does a M. marinum infection look like?
It typically causes a chronic skin infection with granulomas. You might see nodules or pustules, usually on the hands or arms, that develop slowly over weeks or months.
So slow growing and usually on the upper limbs. Are the lesions painful?
They can be tender, but sometimes they're not painful at all.
Interesting. And what about M. ulcerans? What makes it unique?
M. ulcerans. This one causes Buruli ulcer, a really nasty skin infection that's a major problem in tropical and subtropical regions. If it's not caught and treated early, it can cause serious disfigurement and disability.
That sounds scary. Why is Buruli ulcer so bad? What does it look like?
It starts as a painless nodule or swelling, often on the legs or arms. As the infection progresses, the nodule breaks down, forming a large ulcer that looks like it's been eaten away. The edges of the ulcer are undermined, and there's often dead tissue present. And these ulcers are usually painless, at least at first, but they can get infected with other bacteria, which causes pain and more tissue damage.
It sounds awful. And if it's not treated?
The ulcers can extend deep into the tissues, affecting muscles, tendons, and even bone. It can lead to long-term problems with scarring and limited movement.
Where does M. ulcerans come from? How do people get infected?
We don't know the exact source, but it seems to be linked to slow-moving or stagnant water. Insects, especially those that live in water, might play a role in transmitting the bacteria.
So it's another water bug, and exposure to contaminated water seems to be a key risk factor. Is there any way to prevent Buruli ulcer?
Wearing protective clothing, like long pants and sleeves, can help reduce the risk. And there's some evidence that the BCG vaccine, which is used to prevent tuberculosis, might also offer some protection against Buruli ulcer, but we need more research to be sure.
Let's talk about treatment. How do we tackle M. marinum and M. ulcerans infections? Any specific antibiotics?
For M. marinum, our go-to drugs are rifampicin and ethambutol, just like we use for some other NTM. Treatment usually goes on for a few months, and we need to keep a close eye on patients for side effects from the antibiotics.
And for M. ulcerans?
Ulcerans is a tougher nut to crack. Antibiotics alone aren't usually enough to cure Buruli ulcer. We often need surgery to remove the infected tissue, and even then, it can take a long time to heal.
So it's a combination of surgery and antibiotics with a focus on preventing complications and minimizing disfigurement.
Exactly. The World Health Organization recommends 8 weeks of rifampicin and streptomycin, followed by surgery. After surgery, some patients might need skin grafts to cover the wounds and physical therapy to help regain function.
Okay, let's move on to another group of NTM, the rapidly growing mycobacteria. These guys can cause a wide range of infections, from skin and soft tissue infections to more serious disseminated disease.
We mentioned them briefly earlier when we were talking about infections related to catheters and implanted devices.
Right, but they can cause a lot more than just those types of infections.
Absolutely. And they can be a real challenge to diagnose and treat because they're often resistant to many antibiotics.
So which species of rapidly growing mycobacteria are we most likely to see in the lab?
Mycobacterium fortuitum, Mycobacterium abscessus, and Mycobacterium chelonae. They're everywhere. Soil, water, dust, you name it. And they're very adaptable, which makes them hard to get rid of.
So it's virtually impossible to avoid them completely. What kind of infections do they cause?
They can infect the skin and soft tissues, especially after an injury or surgery. They can also cause lung infections, swollen lymph nodes, and even spread throughout the body in people with weakened immune systems.
Okay, let's break that down a bit. What do skin and soft tissue infections caused by rapidly growing mycobacteria look like?
You might see red, swollen, tender nodules or abscesses. These infections can develop slowly and hang around for a long time, even with antibiotics.
And what about lung infections?
Lung infections can range from mild symptoms like bronchitis to more severe pneumonia. Patients might have a cough, produce phlegm, have chest pain, and feel short of breath.
How do we diagnose rapidly growing mycobacterial infections? What are the key steps?
Like with other NTMs, we need a combination of clinical evaluation and laboratory testing. Growing the bacteria in culture is essential, and because these organisms grow quickly, we often get results within a week.
That's definitely faster than some of the other NTMs we've talked about. Getting a quick diagnosis can be really helpful in these cases.
Absolutely. And once we've grown the bacteria, we can identify the species and perform susceptibility testing to figure out which antibiotics will work best.
How do we treat rapidly growing mycobacterial infections? What are our options?
We usually use a combination of antibiotics. The specific drugs depend on the species and the susceptibility testing results. Because these bacteria are often resistant to multiple antibiotics, susceptibility testing is really important to make sure we're using the most effective treatment.
Are there any specific antibiotics that are commonly used for these infections?
Some of the common ones include clarithromycin, amikacin, ciprofloxacin, imipenem, and linezolid. We might use them alone or in combination, depending on the specific situation.
And how long do we typically treat for? Is it a long haul, like with some other NTM infections?
It varies depending on the infection's severity and location, but it often takes several months to fully eradicate the bacteria and prevent them from coming back.
Anything else we need to consider when managing these infections? What about surgery?
We might need to surgically remove infected tissue in some cases, especially for skin and soft tissue infections. If a medical device is involved, like a catheter or an implant, we usually need to remove it to cure the infection and prevent it from coming back.
It sounds like treating rapidly growing mycobacteria requires a multi-pronged approach. We need to remove the source of the infection, like a device or infected tissue, and we need to hit it hard with the right antibiotics based on susceptibility testing. It really is a team effort, with clinicians, surgeons, and microbiologists all working together.
You're absolutely right. It's a collaborative effort to ensure the best outcome for the patient. Now, let's talk about another fascinating NTM species, Mycobacterium haemophilum. This one can cause a variety of clinical problems.
What's so fascinating about M. haemophilum? What makes it stand out from the crowd?
Well, it's a bit picky. It needs very specific conditions to grow in the lab. Unlike most mycobacteria, it needs extra iron in its food, and it prefers a cooler temperature.
It sounds like a bit of a diva. If we don't cater to its needs, we might miss it completely.
Exactly. We have to have a high index of suspicion. If we think it might be M. haemophilum based on the patient's symptoms, we need to make sure the lab is using the right conditions to grow it.
So who's most likely to get a M. haemophilum infection? Is it similar to other NTM where immunocompromised individuals are more susceptible?
Yes, people with weakened immune systems, especially those with advanced HIV, are most vulnerable. It seems to have a preference for people with compromised immune defenses.
What kind of infections does it cause? Does it usually affect the lungs, or can it spread to other parts of the body?
It can cause a variety of infections. It can affect the skin, joints, bones, and in some cases it can spread throughout the body, causing disseminated disease.
So it can present in a variety of ways, depending on the location of the infection and the patient's immune status. Let's dive into those skin lesions a bit more. What should we be looking for? Are there any telltale signs that can help us distinguish M. haemophilum from other skin conditions?
The skin lesions often look like reddish-purple nodules or ulcers, typically on the arms or legs. They can be single or multiple, and sometimes they're tender to the touch. Interestingly, they can resemble Kaposi's sarcoma, especially in patients with AIDS.
That's important to know. We could easily misdiagnose it if we're not aware of that potential mimicry.
You're absolutely right. It just highlights how important it is to keep a broad differential diagnosis in mind when we're evaluating skin lesions in immunocompromised patients.
So if we see these types of lesions in a patient with a weakened immune system, we should definitely consider M. haemophilum as a possibility. How do we confirm the diagnosis?
We can confirm the diagnosis by culturing the bacteria from a skin biopsy. But remember, we need to use those special culture conditions we talked about earlier, iron-supplemented media, and a lower incubation temperature. If we don't, we could miss it.
Right, it's a bit finicky in the lab. What about joint infections? What are the typical features of M. haemophilum arthritis?
Haemophilum can cause septic arthritis, which means the joint is infected. This can cause pain, swelling, stiffness, and make it difficult to move the joint.
So it can look like other types of arthritis, making it difficult to diagnose. How do we distinguish M. haemophilum arthritis from other causes?
It comes down to clinical suspicion, especially in patients who have risk factors like HIV or other conditions that weaken the immune system. We need to aspirate fluid from the joint and try to grow the bacteria in culture. And again, remember those special culture conditions for M. haemophilum.
Okay, so let's talk about treatment. How do we manage M. haemophilum infections? Do we use the same combination antibiotic approach like we do for other NTM?
Yes, antibiotics are our main weapon against M. haemophilum. The tricky part is that this species can be resistant to many common antibiotics, so susceptibility testing is crucial. We need to know which antibiotics will actually work against the specific strain we're dealing with to guide our treatment decisions.
So we need to choose our antibiotics wisely. Are there any specific antibiotics that are particularly effective against M. haemophilus?
Ciprofloxacin, clarithromycin, rifabutin, and rifampin have all shown good activity against it. But again, susceptibility testing is key to make sure we're choosing the right drugs for each patient.
So it's like other NTM infections. We often need combination therapy and a personalized approach based on the individual and the specific bacteria we're dealing with.
Precisely. And treatment can be lengthy, often lasting for several months to ensure we completely eliminate the bacteria.
Before we wrap up our NTM discussion, I want to touch on a few other species that, while less common, can still cause problems. There are many out there, but let's focus on a few that are particularly relevant to clinical practice.
That sounds good. It's always good to be aware of these less common species because they can sometimes throw us a curveball, both in terms of diagnosis and treatment.
Let's start with Mycobacterium scrofulaceum. What can you tell us about this one? I know it's a slow-growing NTM, but what kind of infections does it typically cause?
Mycobacterium scrofulaceum is a close relative of EMTHI, both in terms of its genetics and where it likes to hang out in the environment. It's a slow grower, and like MC, it can cause a variety of infections, but it has a particular fondness for causing swollen lymph nodes in children.
Right. It's definitely one we need to consider when we see a child with lymphadenitis, especially if they're otherwise healthy and haven't been exposed to anything obvious that could explain it.
Exactly. And like MT, M. scrofulaceum is often found in water and soil, so exposure to those environmental sources could be a potential route of infection.
How do we typically manage M. scrofulaceum lymphadenitis? Is it similar to how we approach M. acci lymphadenitis?
The approach is quite similar. Surgery to remove the affected lymph nodes is often the preferred treatment, especially for kids. We might use antibiotics as well, but their role in treating M. scrofulaceum lymphadenitis isn't as clear-cut as it is for MC.
What about Mycobacterium simiae? This one sounds a bit more exotic.
Mycobacterium simiae gets its name because it was first isolated from monkeys, but it can also cause infections in humans, particularly those with weakened immune systems.
So it's a zoonotic pathogen. How do people typically get infected with M. simiae?
We don't fully understand how it spreads, but it likely involves contact with infected animals or contaminated water.
And what kind of infections does M. simiae cause in people? Do they resemble MC infections?
They can. The symptoms of M. simiae infections can mimic those of MC. Lung infections and disseminated disease are the most common presentations, especially in people with weakened immune systems.
So it's another one of those NTMs that can cause diagnostic confusion. We need to be aware of it and consider it as a possibility, especially when we're dealing with patients who have traveled to areas where M. simiae is found or who have had contact with monkeys.
Exactly. And the treatment is similar to that of MAC, relying on combination antibiotic therapy.
Now let's move on to Mycobacterium sulgi. What's unique about this one?
Mycobacterium sulgi has an interesting quirk. It's a scotochromogen at body temperature, but a photochromogen at lower temperatures.
Hold on, it changes color depending on the temperature. That's pretty cool. Can you explain that a bit more? What do scotochromogen and photochromogen mean in this context?
A scotochromogen produces pigment even in the dark, while a photochromogen only produces pigment when exposed to light. So when M. sulgi is grown at 37 degrees Celsius, which is our body temperature, the colonies will be yellow-orange, even if they're kept in the dark. But if we grow it at a lower temperature, like 25 degrees Celsius, the colonies won't have any color unless we expose them to light.
That's a neat adaptation. Why does it do that?
We don't know for sure, but it might be a way for the bacterium to adapt to different environments.
What kind of infections does M. sulgi cause? Does it mimic tuberculosis like some other NTMs?
Like other NTMs, it can cause a range of infections, with lung disease being the most common. And yes, it can resemble tuberculosis, both in terms of symptoms and what we see on a chest x-ray.
So another diagnostic challenge. How do we typically treat M. sulgi lung infections?
We treat it much like other NTM lung infections with combination antibiotic therapy. Rifampin and ethambutol are usually our go-to drugs. The length of treatment depends on how severe the infection is and how well the patient responds to the antibiotics.
Okay, let's move on to Mycobacterium paratuberculosis. This one sounds like it might be more relevant to agriculture.
You're right. Mycobacterium paratuberculosis is mainly a problem for cattle. It causes a chronic intestinal disease called John's disease.
So it's a veterinary pathogen. But does it have any implications for human health?
There's been some debate about a possible link between M. paratuberculosis and Crohn's disease in humans. Crohn's disease is a chronic inflammatory bowel disease that causes inflammation in the digestive tract.
So the idea is that M. paratuberculosis might trigger or worsen Crohn's disease in some people. Is there any evidence to back this up?
The evidence is mixed, and we need more research to determine if there's a real connection. Some studies have found M. paratuberculosis in tissue samples from people with Crohn's disease, but others haven't been able to confirm this.
It's an interesting possibility, but it seems like we need more definitive proof before we can say for sure.
I agree. It's an active area of research, and hopefully future studies will give us more clarity on the potential role of M. paratuberculosis in human disease.
Finally, let's touch on Mycobacterium genevents. What can you tell us about this one?
Mycobacterium genevents is another slow-growing NTM. It's often found in people with severely weakened immune systems, particularly those with advanced HIV infection. It can spread throughout the body and can be tough to diagnose and treat.
What makes it so challenging to diagnose?
It's a very slow grower, even slower than MIC. It can take weeks or even months for it to show up in culture, and standard biochemical tests aren't always reliable for identifying it.
So we need to use molecular methods to be sure. What about treatment? Is it similar to what we use for other NTM infections?
The treatment approach is similar, but because it often affects people with severely weakened immune systems, the outcomes aren't always as good. We usually use a combination of antibiotics, often including macrolides, rifamycins, and ethambutol. Treatment can last a long time, and the infection can come back.
It sounds like M. genevents infections can be really difficult to manage, especially in people with compromised immune systems.
They can be, which underscores the importance of diagnosing it early and treating it aggressively.
Well, we've covered a lot of ground today, exploring the diverse world of non-tuberculous mycobacteria. We've talked about where they live, what kind of infections they cause, how to diagnose them, and how to treat them.
We've seen that NTMs are a fascinating and complex group of organisms that can cause a wide spectrum of disease, ranging from mild skin problems to serious infections that can affect the whole body.
And we've emphasized the critical role of accurate identification, susceptibility testing, and individualized treatment plans for successfully managing these often challenging infections.
It's been a whirlwind tour of the intriguing world of NTM.
Absolutely. Now, to test your knowledge and see how much you've retained during our deep dive, let's have a little quiz. Are you ready for a challenge?
All right, bring it on. Question number 1. True or false, a single isolate of Mycobacterium avium intracellulaire from a sputum sample is enough to diagnose pulmonary infection?
Think carefully, everyone. Remember what we talked about regarding clinical context and the difference between colonization and true infection.
Question number 2. Which of the following NTM species is most commonly associated with lymphadenitis in children in the industrialized world? Is it A. Mycobacterium kansasii, B. Mycobacterium avium intracellulaire, C. Mycobacterium xenopi, or D. Mycobacterium marinum?
Think back to our discussion about how often NTM causes swollen lymph nodes and the specific NTM species that are most often involved.
Question number 3. Rifampicin is a key drug in treating pulmonary infections caused by which of the following NTM species? A. Mycobacterium kansasii, B. Mycobacterium xenopi, C. Mycobacterium malmoense, or D. all of the above.
Remember what we discussed about the different treatment regimens for different NTM species?
Question number 4. Buruli ulcer, that nasty skin infection we talked about, is caused by which NTM species? A. Mycobacterium marinum, B. Mycobacterium ulcerans, C. Mycobacterium haemophilum, or D. Mycobacterium fortuitum.
Think about the key features of Buruli ulcer and which NPM is the culprit.
And finally, question number 5. Which group of NTM is most commonly associated with infections related to catheters and implanted prosthetic devices? Is it A. Mycobacterium avium complex, B. rapidly growing mycobacteria, C. Mycobacterium kansasii, or D. Mycobacterium xenopi?
Consider the characteristics of the different NTM groups and which ones are most likely to cause infections in those settings.
All right, those are your 5 questions. Take your time, think them through, and we'll be back in the next part of our deep dive to discuss the answers and wrap up our exploration of the fascinating world of NTM. Until then, keep learning and stay curious.
Welcome back to the deep dive. Ready to see how you did on those quiz questions?
Let's go over the answers and hopefully clear up any confusion about those tricky NTMs.
Okay, the first one was true or false. A single isolate of Mycobacterium avium intracellulaire from a sputum sample is enough to diagnose pulmonary infection. What do you think?
That one's false. Remember, just finding one isolate of MSC in a sputum sample doesn't automatically mean the patient has a lung infection.
Right. We have to consider if it's actually causing disease or just hanging out.
Exactly.
Right.
We need to think about the patient's symptoms, look for other evidence like abnormalities on a chest x-ray, and rule out the possibility of contamination.
So we need to be careful not to jump to conclusions based on one single lab result.
Absolutely. On to question number 2. Which of the following NTM species is most commonly associated with lymphadenitis in children in the industrialized world? We had A. Mycobacterium kansasii, B. Mycobacterium avium intracellulare, C. Mycobacterium xenopi, or D. Mycobacterium marinum.
I think we talked about this one. It's pretty common for MSC to cause swollen lymph nodes in kids, especially in developed countries.
You're right. The answer is B. Mycobacterium avium intracellulare, or MAC. So when you see a child with swollen lymph nodes, especially in those areas, MAC should definitely be on your radar.
Question number 3. Rifampicin is a cornerstone of treatment for pulmonary infections caused by which of the following NTM species? A. Mycobacterium kansasii, B. Mycobacterium xenopi, C. Mycobacterium malmoense, or D. All of the above. I think this one's pretty straightforward.
It is. Rifampicin is a real powerhouse against many NTMs, so the answer is D, all of the above. It's essential for treating those lung infections caused by M. kansasii, M. xenopi, and M. malmos.
All right, question number 4. Buruli ulcer, a necrotizing skin infection, is caused by which NTM species? A. Mycobacterium marinum, B. Mycobacterium ulcerans, C. Mycobacterium haemophilum, or D. Mycobacterium fortuitum.
The answer is B, Mycobacterium ulcerans. Remember, this one produces a toxin that destroys skin and soft tissue, leading to those nasty ulcers that can be so tough to treat.
Definitely an infection we don't want to miss.
Yeah.
And last but not least, question number 5. Which group of NTM is most commonly associated with infections related to catheters and implanted prosthetic devices? A. Mycobacterium avium complex, B. Rapidly growing mycobacteria, C. Mycobacterium kansasii, or D. Mycobacterium xenopi.
If you recall our discussion about those fast-growing mycobacteria...
Right, it makes sense that they'd be the ones causing trouble around catheters and implants.
You got it. The answer is B, rapidly growing mycobacteria. Because they grow so quickly, they can easily establish infections, especially when there's something like a catheter or implant around.
It just goes to show how crucial it is to be really careful with infection control in healthcare settings to prevent these kinds of infections.
Couldn't agree more.
Well, that wraps up our quiz, 5 questions down, and hopefully you've all learned a lot about those fascinating and sometimes challenging NTMs.
It's been a great deep dive into the world of NTM.
It has. And before we go, I want to emphasize something really important for all of our fellow medical microbiologists out there.
What's that?
We play a vital role in tackling NTM infections. Our expertise in identifying these organisms, figuring out which antibiotics will work, and guiding our clinical colleagues on the best treatment strategies is absolutely essential. It makes a real difference for our patients.
Absolutely. And we need to remember that the world of NTM is constantly changing. New species are being discovered, and our understanding of these bacteria is evolving. So it's crucial for us to stay up to date with the latest research, diagnostic methods, and treatment guidelines.
Couldn't agree more. Thanks for joining us on the Deep Dive. We'll be back with another exciting exploration of the microbial world soon. Until then, keep learning and keep those minds curious.